A very good day, my dear postgraduate students. In one of the feedbacks that I had received from you, a student had earnestly asked me to explain the bone marrow reporting. I had taken this diligently and have started preparing a series of this bone marrow reporting. It will not be replacing your entire hematology, but then our approach to a bone marrow reporting. So this will be the slide over here. Every picture, every slide matters. Do not be in a hurry. Over here, I am finding a skin, the subcutaneous tissue, fat obviously. Then there is a bone which is covered by periosteum, and there is a bone marrow. And what is our topic? Bone marrow aspiration. Look exactly where the needle is. Now, I would like you people to kindly explain this picture. Thanks to Mayo Clinic for the wonderful illustration. The patient is lying in a lateral position, made comfortable obviously, not under an anesthesia. So obviously a reassurance would be needed, and it is done under strict aseptic precautions. And as I had explained in the first slide, you find that there is a skin. The rosy skin is over here, and then a subcutaneous tissue and the bone that is being covered by a periosteum. Inside, I am having the marrow, and a stout needle has gone inside. Before I go to the next slide, what are the sites of a bone marrow aspiration? Very fundamental, undergraduate level. Let us keep on repeating them. It can be anterior superior iliac spine, posterior superior iliac spine, manubrium sterni, tibial tuberosity. In some conditions that is being used. Vertebrae. Tibial tuberosity, sometimes in children, it can be done. The importance of these are obvious. Manubrium sterni, okay. You find it's a flat bone, easy to pierce. But then the risk will be an over penetration. You are having the heart of the great vessels. The anterior and the posterior iliac spines are then the next preferred sites. Posterior because the patient will not be anxious at what you are doing. And this is the aspiration. We shall be going to it at a later date in detail. Now, this is a disposable needle. You can have a reusable needle or a disposable needle. Wonderful kits are now available. I would like you people to diligently by heart the parts of this. A is the needle. B is a transverse bar. Obviously, it gives a kind of a support for the aspirating fingers. There is a trocar or a stillet. This is a very important point. A trocar or a stillet covered by a head. And then all these are in turn covered by a large plastic cap. So all this can be covered. There is an insertion aid that is over there, F, that can be used so that you people can go in one direction. There is a pusher rod also that has been given. G is the pusher rod and H is a plastic lure cap. For this particular one, there is a lure cap that is available. So many parts are there. It is better that we know it. The indications. This is a mandatory one. You people shall and will know. When will I know the indications, or when will I do a bone marrow aspiration? When you are studying something primary to the bone marrow. The cells of the bone marrow are being studied, then you do a bone marrow aspiration. Or it can be a peculiar property. as we shall be seeing. So it can be a megaloblastic anemia. Obviously, I am not going to get megaloblast in the peripheral blood. Very, very, very uncommon. Aplastic anemia. Again, it is not a peripheral blood diagnosis. You can get a pancytopenia, but then the aplasia has to be confirmed. Idiopathic thrombocytopenic purpura. Patient has got a severe or moderate thrombocytopenia, and the bone marrow will give us a diagnosis of an ITP. Multiple myeloma, a malignant tumor solely belonging to the bone. So these are certain things which are mandatory. Without this, I cannot make a diagnosis. Then there are some relative indications. Relative in the sense you may or may not do, or it will add to the diagnosis. But it is not mandatory for a diagnosis. Iron deficiency anemia or a hemolytic anemia to study the iron stores. Staging of a lymphoma. Obviously, it comes to stage 4 straight away when the bone marrow is going to be involved. Storage disorders to demonstrate the Gaucher cells also. Leukemia. When a patient is subject to therapy, you find that the cells, they disappear very fast. So much so, the chemotherapist is anxious to know whether there is any reserve in the bone marrow. Therefore, to study the response to treatment, a bone marrow aspiration is done. Also, in a case of a leukemia in a chemotherapy, you people will have to study the stores before you proceed further with the chemotherapy. Subleukemic leukemia. The patient has got a leukemia, you are finding suspicious cells, blast may be there, but the number is not adequate. And the percentage also might not be adequate. So, if you do a bone marrow aspiration, it can be flooded with blood. Tuberculosis. Again, not a bone marrow diagnosis, but then the orthopedician might do a biopsy also, and then you make a diagnosis of a granule. Others, any response to the treatment. That is what you people see. For example, in aplastic anemia, subsequently you find that the marrow is becoming more cellular. Quite encouraging. Not indicated. Two things you people shall and will remember. One is hemolytic anemia. No form of hemolytic anemia is diagnosed by a bone marrow aspiration. The hemolysis is the property of the cell and the destruction is external. Only thing the bone marrow can react. It is not indicated. Second one is any of the deficiencies, bleeding manifestations, we should take utmost care. So these are two things which you people will have to remember. Precautions, of course, we shall be taking care in the later classes. The procedure. This is almost akin to your peripheral smear preparation. So after making an aspiration, the contents are being discharged onto a slide, and this is a spreader at a particular angle. Usually what I say is, whenever the aspirate is expressed onto a slide, it is admixed with blood. And when we make a smear, it is diluted with peripheral blood. What De Cruchy and the other books say is, you siphon off the excess blood by using an ordinary syringe and needle. So you will be having only the marrow particles. So just like a peripheral blood smear, you bring the spreader backwards so that it touches, and then there is a capillary action which makes the aspirate spread along the spreader. And finally, you find that with a deliberate movement, there should not be any seesaw movement or a jerky movement. With a deliberate movement, you make it, and finally the smear is over. Let us see what you people have done. I have mentioned something like cell trials, etc., marrow particles. What are all these? What do they mean to us? So this is one thing. It is almost like a mini surgery. Strict aseptic precautions are needed. You cannot do it in an open ward, etc. So this is the outer table of the diploid, the inner table and the compact bones, and in between them we have got the spongy bone of the marrow. This is exactly where I should be. The external surface, that is the skin, is being cleansed with lignocaine or spirit, and it is injected with 2% xylocaine as a local anesthesia, because skin is a very sensitive organ. Therefore, there will be a sense of pain. After which you find that there is a bone marrow needle which is made to penetrate. The procedures we'll be dealing with later. Now, this is a bone and this is a spongy bone where the marrow is. After piercing the outer table, I will feel a sense of giving in. Take a plywood table and you pierce a needle. Once it goes into the powdery material, you find that it has yielded. That means you are in the marrow. Attach another syringe and only the syringe, no needle here, and you do the aspiration. Ideally, the aspirate must not be more than 0.2 to 0.3 ml. Very great mistake is done whenever they aspirate 5 ml, 10 ml, and then they say the pathologist gives a report that the aspirate is diluted with very few. Obviously, it will be. Let us make use of this picture. Look at the innovation nowadays. It is a bone marrow biopsy that is being done, and this is used for the cutting and the biopsy. Simultaneously, I find that there are some pores outside or holes outside the needle, and it is a literal double barrel. So what happens is you find that the marrow aspirate goes in by means of this adjoining pores, whereas the biopsy that you are cutting and taking comes into this needle. So it is a two-in-one technique. We shall be dealing with these techniques later on. So our class is to be continued. We have started with a bone marrow aspiration. Thank you.